we will have Mr. Eric Ngereso, a nutritionist at KNH as well, and he will be taking us through the topic of the role of healthy diets in cancer prevention. So I would like to request us to keep our mics muted. We shall have a Q&A session at the end of the webinar. However, please feel free to type in the chat if you have a question, and let's have an interactive session. So without a lot of ado, I think just by means of agreeing on our norms, I think to avoid, if you want to have a better reception, it may be better to keep your camera off. I would like to request you to stay muted unless you're speaking in the meeting, and otherwise you will also be muted so that we can concentrate and have a very vibrant time in our webinar. So without any much ado, I want to invite Mr. Jude Otogo to share his screen and take us through what are these policies around healthy aging in Kenya.
Thank you very much, Dr. Bor, for inviting me to speak in this webinar. My name, as already introduced, is Jude Otogo. I am the country representative for HelpAge International in Kenya. Before, I was the Africa Regional Health Programs Coordinator for HelpAge International until last year when I assumed my current role. Just trying to load my slides. Just give me a minute. Okay, can you see my screen?
Yes, we can see your screen, and request that you put it in slide share. Great, wonderful.
All right. That is basically the outline of my presentation. I'll give a very brief overview of HelpAge International for those that are not familiar with the organization, and a very brief overview of population aging and healthy aging before we eventually dive deeply into healthy aging policies, broken into policy imperatives, policies and other framework, and then we shall look at the Kenya National Health Aging and Older Persons Health Strategy. So HelpAge International is basically a secretariat organizations that work on advancing the rights and well-being of older persons globally. HelpAge International is present in 85 countries and has a network membership of over 158 organizations. What HelpAge does is to promote well-being of older persons, promote their inclusion, work towards reducing poverty and reducing discrimination. You will understand why I'm talking about those four thematic areas. So our vision is a world where every older person says, I have the income that I need, I have the best possible health, I am safe and secure, and my voice is heard. That is HelpAge in a nutshell. So population aging, what's happening? First of all, when we talk of older persons, both the Kenyan Constitution and the UN define an older person as an individual aged 60 years and above. And the number of older persons is growing faster than ever before, and faster than any other population segment. And this is particularly visible in Africa, which is experiencing the fastest growing number of older persons. It's estimated that by the year 2050, the population of older persons in Africa will outnumber that of children. And of course, the population itself is aging. People are living longer. What's happening in Kenya? First of all, life expectancy is now at 66.7. This might have changed over the last 2 or so years. Majority of our older persons are female at 55% of that population cohorts, and they live in rural areas. It's also thought that about 18% of the country's households at least have an older person. That's according to the KIHBS of 2015-2016. Something to note is that population aging offers both opportunities and challenges. I will, however, dwell on the challenges because that's why we are healthcare workers. That is just a schematic representation of the demographic trends. In 1949, we had just about 270 older persons. That figure has risen to 2.7 million as of 2019 when the population census was carried out. What are the issues that affect the older persons? Broadly categorized, we have issues around healthy aging. We have issues around income security or social protection. Issues around violence, abuse, and neglect, as you might have realized from the recent news highlights. Sorry, there seems to be some noise. As you might have realized from the recent news highlights. And then there's the aspect of ageism. Those are the 4 main issues that are affecting older persons. I'll briefly just touch on healthy aging as an area. It's very easy for us to assume that we know what healthy aging is all about. But the WHO defines healthy aging as the process of developing functional ability for well-being in old age. And that functional ability should enable us to be and to do what we value. To be and to do what we value. If you look at my screen or my slide, you can see what those things are. The things we value include being mobile, ability to learn, grow, and make decisions. We should be able to meet our basic needs. We should be able to make a contribution to society, and we should be able to build and maintain relationships. As we age, these are the fundamental things that all of us would love to experience when we are 60 years, when we shall have exited gainful employment. So what are the challenges that we face in terms of healthy aging? Basically, with the advancing age, we are exposed to different forms of health conditions. What we are referring to as an epidemiological transition. We are increasingly seeing more cases of chronic infectious diseases, including tuberculosis among older persons, non-communicable diseases that sometimes come in more than just one form. That is, multimorbidity is very common. Injuries and disability, and the forms of disability include physical, sensory, and cognitive. These health-related vulnerabilities are mainly from the triple burden of disease and is complicated by the weak health systems. I have this slide, which is basically giving us some information about a recent study undertaken by HealthPage, led by the University of Nairobi in the sub-counties of Kibra, Dagoretti South, and Dagoretti North. It goes to reinforce the message that non-communicable diseases are quite prevalent among older persons. And as you can see, up to about 20%, that's 18.9% of all older persons aged 60 and above have at least three NCDs occurring concomitantly or at the same time. What are the health systems challenges that older persons face or that we face while supporting healthy aging? One, we have weak community health and long-term care systems. That includes both the conventional health systems building blocks and the traditional care system. Secondly, our healthcare systems are disease-oriented in the sense that we focus on specific diseases when we should actually be focusing on improving functional abilities and intrinsic capacities of older persons. Thirdly, the system is characterized by fragmented services. And finally, we have quite a weak policy environment that does not support healthy aging effectively. I just thought that we would remind ourselves of this very famous building block framework for health systems. When it comes to healthy aging, what exactly should we be doing in terms of strengthening health systems? First of all, at the service delivery, we should be creating age-friendly or age-appropriate health infrastructure. I don't know how many of our health facilities have already addressed this, given the unique needs and challenges that older persons face. The second area is an area of human resources. The need to transform the health workforce to be able to effectively respond by building their capacities for health service delivery that responds to the unique healthy aging challenges that older persons meet. The third area is health information systems and e-health. Investments in this area are key. Today, I'm not very sure that I would find longitudinal data and sectional data that is disaggregated by age, sex, and disability when it comes to older persons age 60 and above. And probably further, it may not be able to effectively quantify the health conditions or healthy aging issues that older persons face when we do not have data that speaks to those criteria. The fourth area is medical products, vaccines, and technologies. As mentioned earlier in my presentations, older persons basically are faced by a different type of disease burden. For instance, we are talking of NCDs. Do we have adequate medications? Do we have adequate consumables specific to the condition that older persons face? With age also and effects of non-communicable diseases, these older persons develop some abilities, especially sensory disabilities. Do we have assistive devices to respond to that challenge? The other area is leadership and governance. We talked about weak policy framework, and I will not emphasize any more than I have already. Health financing, what proportion of our health budget is dedicated to the healthy aging needs of our population? And finally, reframing medical research. We cannot be able to effectively respond to the needs of older persons unless we have an evidence base that speaks to their challenges, to their context, and all those other issues. I will now look at healthy aging policies. Why do we need healthy aging policies in the first place? One, these policies form a framework that guides the establishment and implementation of interventions to support healthy aging. Secondly, they serve to address system challenges that are faced while in defining program aspirations for healthy aging through implementation frameworks that normally come with the policies and strategies. Please allow me to just quickly take you through some of the policies and the other frameworks that exist in support of healthy aging. We have the Madrid International Plan of Action on Aging of 2002, which focuses on advancing health and well-being well into old age and ensuring enabling and supportive environments for healthy aging. We also have the Active Aging Policy Framework of the same year, which informs plans for active and healthy aging. We have the Sustainable Development Goal number 3 and the Clarion Call of Leave No One Behind. Both form a firm basis for targeted responses to aging and health. Healthy aging. The United Nations Decade of Healthy Aging aims at improving lives of older people, their families, and the communities within which these older people live. We have the African Union Policy Framework
Jude, your screen has disappeared, I think, and we are not hearing you. Perhaps a network issue?
I think we've lost him, eh?
Yeah, perhaps we could be having a network issue. I expect that he will promptly rejoin. And thank you, everybody, for joining us. I think even as we continue with the webinar, perhaps you are wondering why cancer and aging, because this is not an everyday kind of topic that we may be used to. So I will just give you some background a bit on why we are discussing cancer and aging. And Charles, perhaps you can check on our speaker. You can call him and find out if he's having a challenge. So okay. I'll give you and then alert me when he has joined. But I would just like to give us a brief background. Cancer develops at any age, but actually the incidence of cancer rises dramatically at a later stage in life. So aging has been known to be a risk factor for most cancers. When you look at the incidence rates for cancers, along with the different age stages, you find that among people below age 20, these are children, there are fewer than 25 cases per 100,000. Then when you go to the age group of 45 to 49, you find that the incidence of cancer rises to 350 per 100,000. And then when you go now to the age of older, 60 years and older, then you find that there are 1,000 100,000. So you can see that there is clearly a difference between, in terms of cancer incidence, between younger people and older people. All over the world, you find that more than half of people who have cancer and who end up dying from cancer are over 65 years old. In Africa, where the population is relatively younger, cancer among the old accounts for 29% of total cases and 36% of related deaths. But as the population ages, as people live longer, that is expected to go up. So you can see how relevant the topic is of cancer and aging. And when Jude will be able to join us back, I'll invite him to continue telling us about the policies so that we can see what role we have and be enlightened about preventing cancer in older people, what the policy environment is, whether it supports that or not. So I'm going to invite Roslyn Okumu, Chair of Oncology Nurses Chapter Kenya. She's a nurse who works at the Kenyatta National Hospital Cancer Treatment Center. Roslyn, you can prepare to share your screen and take us through cancer prevention. And then we can follow that session with a session on nutrition as a way of preventing cancer. Welcome, Roslyn.
Hello.
Hi, Roslyn.
Hi, good evening.
Good evening.
I'm going to request that, if possible, Charles to help me to share the slides.
Okay.
Some technical hitch here.
Okay.
I had sent to him
Charles,
on email.
kindly help Roslyn to project.
Unaona nini hii? Unaona hiyo issue ya pharmacy? All patients wenye bado
Kindly
wana pick
remember
oral
to keep
medication.
yourself muted. Clementine, kindly mute yourself.
So unaji-unmute.
I'll also give you a few more facts about the population's aging at an increasing rate in Africa. For example, Kenya's median age in 1980, it was 15 years. In 2021, it is 20 years. So you can see there's a difference. It is projected that by 2050, the median age of our population in Kenya will be 28.1 years. So you can see that our population is aging, which means that our governments will have a limited period of time to develop policy and health systems that will respond rapidly to the issues of the aged. So as we have seen, cancer is more common among older people. And so the increase in the aging population will have consequences for cancer in our country. So we need to focus on cancer and aging now. And that is the reason why we are having this webinar. Welcome, Roslyn. Please continue.
Thank you very much for the opportunity. As you are told, I'm Roslyn Okumu. We are going to discuss this topic, and we're going to have objective of introduction and background. Then we're going to talk about cancer prevention in terms of the primary prevention. And then you're going to talk about secondary prevention, and then what are the specific issues that we were able to address in regards to the elderly. Is it clear, or am I clear? Just to get to understand.
Yes, Roslyn, you're clear. We are getting you very clearly.
Okay. So So as Dr. Bor has just been giving us the status update on how our aging population is, and we have seen that more than 2/3 of all new cancer cases are diagnosed among adults who are aged 60 years and older. And as the number of adults living to the elderly population increase, so then we expect increase in rising of cancers. So for example, in 2018, globally, we had more than 1.7 million people who were diagnosed with cancer. And they were mainly the elderly. So if we do not have efforts to prevent cancer, then we expect to have the numbers increase by 2050, as we've been told. And therefore, we have to start prevention, and cancer prevention then should be happening along the continuum. So this is a problem that is facing many countries. And so Kenya being one of them, we have to be aware so that we start position ourselves to be able to prevent the cancer among the elderly. Next. So we have to put efforts. We can move to the next slide, sorry for this. So talking of elderly, we have to know that even them at some point they were young. And some of these cancers may have started when the person was young. And because of the nature of cancer, we know there are stages of development of certain cancers where it could be precancerous, then it continue evolving up to the level when it becomes cancerous. So we have to start taking precautions early enough in the person's life, so that we get enough opportunities along the continuum to be able to make sure that the person even reaches the old age in a fairly healthy state. So that people at the 60s and 70s can be able to enjoy their old age. So considering that a person of this status of elderly, I was hoping that I had a slide on introduction on the elderly. Maybe we'll get it along the pathway. But the elderly basically is somebody who is 60 years or 65 years. So, and then they can progress up to 80 and 90. So there's the early elderly and then there's the late elderly. So the progress continues. So you realize that at this age, you find there are other comorbidities. You have somebody with hypertension, you have somebody with diabetes, somebody just having some back pain, with some pain on the bones. So we need to figure out how best can this be integrated with the already available services. And again, in that line, we need to consider aspects of screening and detection. That is it. Thank you. Next slide. And again, prevention is key because we talk about 40% of cancers being preventable. And our topic today requires us to focus on primary prevention and secondary prevention. So in terms of primary, there are actually 3 types. The primary prevention is trying to make somebody not get cancer. Whatever actions will try to make somebody who has not gotten the exposure not to get the cancer. And that also goes along the lifelong, because we started in the childhood to all the other aspects and still somebody reaches the elderly life. Then we have the secondary prevention. And secondary prevention is when probably somebody has gotten the cancer, but it is not yet diagnosed. So it is a way in which you want to do some sort of screening, some sort of diagnosis to be able to detect the cancer early enough. That is what secondary prevention would be. Then tertiary prevention is when somebody has been diagnosed of the cancer, then you want to do treatment. You want to even ensure that they are well rehabilitated. For example, you cut your breast, then you need to ensure they have a prosthesis just to ensure they still have quality of life. even in the treatment process. Next. So in terms of primary prevention, we have several factors. And as again, I will have to reiterate that patients, it is along the continuum. You may have gotten an exposure when probably you are in your 30s or in your 20s, and depending with how the evolvement and every other thing, the risk factors and just the specific biological factors within a person, somebody can get cancer at a certain point of life. So in terms of primary prevention, we need to prevent all other chronic diseases. That's why I need to say that we have to ensure that our non-communicable diseases are also treated. Then we need to work on vaccination. For example, you know that conditions like liver cancer can be brought about by hepatitis B. So we need to ensure that the elderly are immunized. And these vaccinations at some point are available in our hospitals, even for free. Again, as we know, there's the HPV vaccination that is given to our youngsters, but we know that it is something that is meant to protect them even in their old age. So we need to ensure that we reinforce the uptake of vaccinations. Then we have to be cognizant of other conditions that lower immunity that then would predispose a person or our elderly to cancers. For example, you find patients who have diagnosis of HIV/AIDS in their 50s, in their 60s, in their 70s, they are struggling with Kaposi sarcoma. So knowing that HIV/AIDS can be prevented, we need to just enlighten our people that is something they need to be working on. But even if they have been diagnosed with HIV, they can still continuously take their drug so that they have good immunity, and that can help alleviate some cancers that are caused by the same. Then we have avoidance of radiation and occupational and environmental exposures. So this could have happened when somebody is at work, because we're talking of elderly being 60 or 70, but you know, at some point they could have been in certain occupations that would have predisposed them to such hazards. So for example, somebody who is working in a very toxic place with chemicals, we need to ensure that as advocates, we advocate for proper protection through the workplaces where the people are, like in the industries. We need to ensure that if somebody is handling carcinogenic items, they are well taught on how to handle those. And even for somebody, for example, us who are already in the cancer care industry where we are administering chemotherapy, we are working in the radiotherapy section, we need to ensure that we protect ourselves appropriately in our working days so that as we retire, we're not going to get leukemia because I was getting current and repeated exposures of the cyclophosphamides, so, and even the radiation. So in that case, the person, like the healthcare worker, must be reminded to be having their protective devices. They must be having their dosimeters in case they're working in the radiation department, just to be able to ensure that the exposure is not extremely high. And if there is, then appropriate action will be taken just as a preventive method. Healthy diets, rich in fruits and vegetables is part of it. I know my colleague who is a nutritionist will be online just to explain more about that. And that is as a preventive method, but I would want to just remind ourselves that we do get prevention as a primary prevention, but should you get to come across a person who is already undergoing cancer treatment, for example, somebody who is on cancer treatment and on chemotherapy, as an advocate, I see Charles has put my other, let me just maintain this one. I hope it's not, let me know if the voice is getting mixed up. So for example, as an advocate, if you get to meet somebody who is already going through active cancer treatment, that is a person who requires all the nutritional components that our nutritionist will be able to give us more information about. But that is a person we need to encourage to eat as much as possible and to eat the bodybuilding food, even if it means taking animal protein, because you find that we go telling them, do not take nyama, do not take so many things, then take only white meat, and then you realize even affording the problem, they then end up with starving, then they get to cachexia. It's a state where they are so wasted. So that is not the point we want to be talking about diet, and do not, that's the time we want them to take as much so that they build up their body, they have enough blood, and they consistently maintain their treatment. So that's a disclaimer when you are talking to our colleagues and patients outside there. Then we need to encourage regular physical activity and maintain healthy body weight. You find that people at times when they are a little bit bigger, or people who are a bit overweight, are likely to get certain cancers. And the reason being, some of those fatty tissues are able to produce some hormones that would then predispose the person to the cancer. So we need to ensure that we encourage our community to have healthy body weight. Then we need to minimize exposure to aflatoxins in food. And this is our core mandate, because if the food is well stored, then that means we are going to eat healthy food. But you realize that in terms of the business orientation within this country, and also with the challenges we are facing, people just want to make business. So as advocates, we need to find a way of getting engaged, even to inspecting where cereals are stored, and if there is any problem, and even tested, so that if there's any problem, for example, with that maize, then you do not have to consume it, even if it means throwing it, so that the people are in good health. And then tobacco and alcohol control is also mandatory. We need to ensure that we encourage our people to just take minimal, or even to avoid all in all, because we know that there are several cancers that are associated with tobacco and alcohol. Next slide. So in terms of tobacco control, there's the legislation on tobacco control that has been ongoing. We have to advocate for smoke-free environments, both in indoor and workplaces. Like if we are working with people at homes, we know that our kind of cooking, you probably use the firewood and you are inhaling it, and the next time you're having your head and neck cancers. So we have to encourage our people to use modified cooking stone. I've seen some modified that have churn very few smoke. So we need to ensure that we propose such. So we have to do a lot of, as advocates, this is our core mandate again, advocacy on public awareness of tobacco, and then we provide cessation and support services for the smokers. I know people who have really had the desire to stop smoking, but if they stop for a short while, then then they find themselves falling back into it. So there are some means that can always be used through discussion with the healthcare workers. And in certain hospitals, there are these means that can help the patients, or rather the addicts of tobacco, to be able to get that sensation of tobacco, and within a consistent and continuous support, they'll be able then to stop the tobacco smoking altogether. Next slide. So alcohol consumption, we have talked about it. One of the things that I know even is being done as it is by the MOH is to advocate for total ban of the alcohol advertisements. Then to raise public awareness amongst youth, because it is this youth that today they are healthy in their 30s, in their 20s, but then over and over and over and consistent consumption, they'll be ending up with liver cirrhosis. So this cancer prevention in the elderly has to start all the way from the young child to the middle age up to the elderly. So we have to ensure that we mitigate such like alcohol consumption. Next. Again, on diet, I had said we need to promote healthy diet and physical activity. My colleague will be talking about it. Then for the ladies who are still within their childbearing ages, they need to breastfeed a lot, because even that is protective to the, because of the hormonal involvement in it. Then our diet, again, I will continue reinforcing. Then there is a need for control of environmental exposure to carcinogens. We have talked about it. Industrial waste also must be well disposed. So if we know, and another thing that is coming up is everybody's developing or having a cancer center. So if we also happen to know that there are people who are disposing those toxic materials, for example, the chemo waste within the estate, it's our business as the health advocates to be able to bring this to the attention of the proper agencies so that action is taken, so that we're not having toxic carcinogens thrown all over. And again, as I said, for those of us who are in our workstations, we must use our proper protections if you're handling these chemotherapeutic agents. And there should be radiation exposure surveillance amongst the staff who are also one day going to be old, so that with the surveillance, we're able to notice if there's any deviation from the normal and handle it appropriately. So I just talked about the biological agents, and of which I had said that we need to ensure that there is immunization for those cancers that could be prevented through immunization, like HPV, immunization like hepatitis B immunization. And as I said, again, we need to strengthen promotion of infectious disease related cancers. We need to ensure that we strengthen and we ensure that we empower people to be vigilant. And then promotion of healthy sexual behavior. Some cancers are sexually transmitted, and therefore we have to ensure that we teach proper sexual behavior to all the people along their life cycle. And if there is anybody who contracts infectious disease, then we need to ensure that they are treated promptly. So some of the infectious diseases that are also likely to cause cancers, in addition to the ones I had said, are H. pylori. H. pylori is one of the reasons why people get cancer of the stomach. And even this, you realize it comes when somebody is about 50 years to 60 years. So if we happen to get to hear people who are having abdominal bloating, just that feeling of discomfort in the abdomen, and then we need to be cautious and we need to ask them to go and do their H. pylori treatment, test and then treatment, because H. pylori can be very difficult to treat. It needs the right people with the right investigations and the consistency of treatment. And even once the person is done with the course of antibiotics and treatment that are normally scheduled, we would want that kind of a person to go for another test to just confirm that the H. pylori is totally cleared, because it's one of the reasons why people get some stomach cancers at some point. So having talked about primary, and I said primary is just trying to prevent that disease before it happens. So basically what you are trying to talk about is ensuring you have healthy lifestyle, ensuring that we we are doing immunizations, we are doing exercises, eating healthy, treating all infections just before they progress. And in terms of secondary prevention, I had said it includes early detection of the disease when it has the high potential for cure. For example, breast or cervical cancer, they have good prognosis if they're detected at an early stage. So, and we have various interventions again in line with that for cancer screening. For people, for cervical cancer, there's a lot of screening that can be done on that. For breast cancer, we have a lot of screening that can be done on the same. So we have the strategies within secondary prevention. We have early diagnosis and screening. And the detection is only successful when we link to effective treatment. So in terms of, as we're going to progress with the secondary prevention, should we get somebody who has a suspicious condition when you're doing our screening? For example, when you go for our mass screenings or when we are linking our patients to service delivery, let us ensure that they are promptly linked so that you have the alarm, you are linked to a place where you'll have a mammo and even a biopsy done, and thereafter there's a follow-up to be able to handle the patients on time and to be able to get into early diagnosis. And so in terms of early diagnosis, we want to detect the symptoms as early as possible again. And it can be achieved through creating awareness of possible warning signs of cancer amongst our population. So that just as we continue again, you'll see a slide that will be able to give us just that suspicion index. You see this kind of a condition, and then you're able to think there's need to do some investigation. So there's 3 steps in early diagnosis where we need to create awareness. And as advocates, that's our core mandate, to create awareness of cancer. And along other care pathway, they support in terms of availing their diagnostic capacity and then improving treatment. So the warning signs that we need to know as the people who are involved in cancer care is, for example, in cervical cancer, if you get to hear somebody having postcoital bleeding or excessive vaginal discharge, that is a warning sign of cervical cancer. And again, in terms of cervical cancer, elderly are probably menopausal. So if you find a menopausal lady who is 55 and suddenly she's started having PV bleeding, that's a key indicator that the person could be having a problem along the cervix, and therefore we need to send that person for the screening and even testing, because we realize that as the people continue aging, you may not be able to call them for that mass screening for cervical cancer, especially after they are 49 years of age. But one of the things that you can still do is to ensure that we remind them to go for the individualized checks. So that is a concern. Then if a person presents with breast lump and there's the asymmetry in skin, asymmetry, for example, the breast, you find one is extremely larger than the other, because normally you find there's one that is a little bit larger. If they find that one is slightly grown larger, and then there's the skin retraction at the nipple, they're normally diagrammatic representation of the same. Maybe you can share in another forum. And nipple retraction and blood stain in the nipple. Then there's also a cause for alarm for breast cancer. We need to send this kind of a person for testing. So in terms of investigations, according to MOH, we need to be doing ultrasound for the younger generation. Then as they continue growing, then we need to be doing also clinical breast exam. That should be happening to all ladies, clinical breast exam. At least all of us should be able to do it at least once a year. But as the person keeps growing, then we realize that you reach 60 or you are 50s, we still encourage mammogram to be done at least every 2 years, especially for somebody who had not had a suspicious mammogram. We would want that to be done at least every 2 years, with the CBE, which has to be done yearly. But again, on the same note, the person should be aware of their breast so that there are changes, then they're able to know. And normally in the previous sessions, we have been told that we need to be doing breast exam at least once a month. This is a person who is probably menopausal. They may not be able to tell when exactly to do this breast exam as guided by their periods. So we can encourage them to just be aware. You go to shower, always learn to touch the breast, look at them on the mirror, just be aware. But if you have to do that self-breast exam and they would want it to be done once a month, then they can choose maybe the first day of the month or the last day of the month, if that can just help them to do something more consistent. You find that even at that age, they have a little more time with themselves. So if they have a little more time, then they would want to be, if they're enlightened, they would want to take any precaution. Then for colorectal cancer, again, this comes. It can happen even when somebody's 30s or 40s, but we realize that it also comes with age. Change in bowel habits, unexplained weight loss, anemia, and blood in stool. Colorectal cancer, if detected early, can be prevented. And so in the elderly, even though we are talking of, now we're talking of secondary, where we want to early detect. Maybe I want to give you a scenario of a patient somewhere. I had a patient who had a problem with the stomach. She was feeling the stomach is feeling so full. And she was feeling like her bowel habits have changed. And so when she went to see a family doctor, the doctor sent her for stool for occult blood. And that stool tested positive. And according to our cancer screening guidelines, that is one of the key tests that we want to do, just to be to get it as a baseline to be able to rule out colorectal cancer. So when she took it to this doctor, the doctor said now you needed to go for colonoscopy. So it was looking like you are on the right track. But now going for the colonoscopy, at that point she happened to have some abdominal distension. And the doctor, instead of doing colonoscopy, then calls a gynecologist and says this person presents like she has ovarian cancer. The reason being, when you have ovarian cancer, at some stage you realize somebody has ascites, so the stomach just suddenly swells. So now they start concentrating on ovarian cancer, and they say this ascites looks like the patient is having pressure to breathe, so she's not breathing well. So suddenly they schedule the patient for an ultrasound, and there's something that is not right in the ovary. And then they decide to take the patient into theater. And when they go to theater, they say the surgery is very difficult. And so they come out after 10 hours, and they say this patient had gone through a very difficult surgery. They found that they have removed the ovary, they have removed the uterus, and they're sure the cancer is gone. But they also realize that on the omentum, on the just along the colon, they also said the cancer had extended, and they also removed some bit of the colon in between the surgery. And that is what made the surgery difficult. So then they said because the surgery appeared difficult, this disease must have progressed. So they put the patient on carboplatin and paclitaxel. And the patient does the 6 cycles religiously, goes through the heavy side effects. And then after 3 months, the patient is back. Her stomach is still not fine. She is still feeling like her stool she's having constipation. She's just not fine. And then she goes to the doctor again, now the guy, because now she had been pre-channeled. And the guy tells us, your disease seems to be really having a bad prognosis. We are starting you on second-line chemo, and we are not promising you good outcomes. So with that, the patient is put on another drug called liposomal doxorubicin. Another heavy side effects comes in. The patient is anemic. Now she's in that cachexia state. And now she knows she's going to die. And when we ask for further tests to be done by the doctor, even to do the liver function, because now the liver appears distended. And the doctor says, no, there's no need of doing so many tests. This patient is likely to die. Then with that, we had to insist. And after insisting on all that, we found out that we were treating a wrong diagnosis. The patient did not have CA ovary. The patient went now through another set of tests because the doctors who were treating her gave up on her. And so they took her through another process of tests, and they realized that the problem was cancer of the colon. No wonder she had positive fecal occult. No wonder she had other biomarkers around CA ovary negative, but around CA colon, they were positive. So one of the things I'm saying is we need correct diagnosis. It is early diagnosis, but it has to be correct. These are patients we have wasted a whole year treating for something very wrong. So as advocates, we need to ensure that the people who are running cancer centers are having capacity to diagnose properly and not just to go through their own, and also to have a multidisciplinary, because we wasted a whole 1 year treating something that was not there, and the patient has exhausted all the NHIF, all the insurance. So proper diagnosis is key in cancer prevention in the elderly. And this patient I'm talking about was now 65, just retired. All her money used and yet in the wrong diagnosis. So again, as you can see on the slide, if you're able to see on the slide that is being projected, there are other ways you can detect other cancers. For example, for the prostate cancer, the patient can present with pain and frequency in micturition, in passing urine, and even blood in urine. So those are the indicators of prostate cancers. Then for head and neck cancers, you could have lump in the nose, in the throat. And also for oral cavity, you could have white lesions or red lesions in the mouth. So those are some of the things we need to be careful about and to be able to channel our patients appropriately. Next. We can pass to the next. So we have to do cancer screening to the patients appropriately. The elderly, remember, may not need that cervical cancer pap smear because of age.
Nimesema easy of bringing a pharmacy
Then, as we do our cancer screening, we have to ensure that the benefits outweigh the non-benefits. And as again, we have to link them to the point of care. Next. We can go to the next again to save on time. Yeah, so as we're talking about early detection means you have to screen and you have to early diagnose, and not just diagnosis, but it has to be correct diagnosis so that we are able to do that secondary cancer prevention, early detection. Next. So in terms of the elderly, at least those who have some little financial support would always want to go for holidays, and they would want to just live their life because maybe their working time was really occupied. You find those kind of people choosing to go to the coast, and there's a lot of sunburn. And so with that, we have to ensure that the skin is protected from the sun. And not only for the elderly, but even for every other person, we have to protect our skin from the sun, because the direct sunlight will damage the skin. And so even if we are happening now that we are in the season of festives, if you come to coast, you do not have to, if you have to really put on those short sleeves in a very hot sun, then we have to do sunscreen, even on the exposed areas. And you have to ensure that the person, if possible, can avoid the very hot sun between 10 a.m. and 4 p.m. and to seek the shade.
Kindly requesting those who are not speaking to mute themselves, and kindly requesting that you perhaps wind up. Thank you.
Yeah, I'm actually winding up. We have to ensure that there's sun protection through our outfit and through our skin, and even through just staying in the shade. Next. So our elderly, because we realize that some of these screenings may not be favoring elderly when we call them for the mass screening, we have to encourage them to see their doctors at individualized basis. And how would they see the doctors? We have to tell them the benefits of going to the hospital. we realize that some of them are left alone. We would want those who are not able to consistently access the hospital to be supported by the immediate family members. And if there are no family members readily available to do that, then they can always get a caretaker who knows how best to walk around with the elderly should they be diagnosed of cancer, so that they get prompt treatment. And even as they are managing other comorbidities, they have somebody who's always available to support them just to access the health facility for individualized care. And yeah, that is what I wanted to say. And maybe of concern again is the elderly. Elderly age comes when you are leaving your active employment. So we would want to encourage our elderly to invest in their future health by those who are able to procure insurance to do so, and also those who can just do NHIF to ensure they have NHIF. And more so the team advocates, can we ensure that we continue advocating that cancer screening and cancer care is fully packaged in the NHIF, so that if somebody wanted to do just a fecal occult blood test, which is not so expensive, it can easily be done without necessarily paying from the pocket, rather than waiting until it is late and now we have to just do a colonoscopy in some situations where we can avoid it. So can we just ensure that we advocate that they are financially empowered? And I'm very glad that you listened to me. Those are the references. Thank you so much.
Wow. Thank you very much, Roslyn. What a great presentation. I think for me, my take home, I don't know about you, but I want you to reflect and think about it. What 3 things are you going to take away from this talk? And for me, I have realized that a lot of primary and secondary prevention is supposed to be happening along the continuum of the life of the person. So right now is when we should be preventing cancers that will happen, in older age. And so that for me is one of my take homes. And my other take home is that screening is very important as per the guidelines. Roslyn has mentioned the cervical cancer, breast cancer, colorectal cancer. Let me leave you to digest that, and I would like to welcome our next facilitator, that is Eric Nereso. Eric, karibu. Eric is a nutritionist at KNH and is going to take us through healthy lifestyles as a way, healthy nutrition as part of the healthy lifestyle towards cancer prevention. Once Eric's presentation is done, we will have Jude back to finish up on what he started on policies on healthy aging. And I think as we go through this, that will even make more sense. So I want to request, Eric, that you manage your time well so that we don't go overboard. Thank you. Karibu, Eric.
Healthy eating ndio hii sasa Mari.
Eric, we are waiting for you.
I think he dropped off. Eh?
Oh, Eric has dropped off.
I can't see. I can't
Okay,
see
why
to
don't we switch over to Jude? I want to request everybody to bear with us. Sometimes technology will let us down in unexpected ways. So let's be flexible and adapt. Let's continue with the policies, the healthy aging policies. Then when Eric is able to rejoin, we'll finish with the healthy diets.
My screen sharing is disabled.
Yes,
Are you able
kindly
to
Charles,
activate?
enable Jude to share the screen. Jude left off telling us about the African Union policies that impact healthy aging, and I think you should just pick up from there. I think we were able to follow from the global level, and now we were at the African level, and we'll come to the Kenya level.
Ifaro means
Great. So thank you again, and apologies for the technological glitch. I had gone through this. Can you hear me?
Yes, we can hear you, Jude.
Okay. So I have just gone through this, why we need healthy aging policies, and I say there are frameworks to guide establishment and implementation of intervention support healthy aging, to address system challenges to healthy aging, define program aspirations for healthy aging through implementation frameworks. I had therefore started looking at the specifics of these policies and frameworks. And here are some global and regional, as well as national policy and frameworks. I had gone through this slide. I must have been on this slide where I was talking about the African Union Policy Framework and Plan of Action on Aging, which commits signatory member states to develop policies that ensure older persons enjoy their fundamental rights, while the African Union Protocol stipulates the health and care responsibilities of state parties. It's actually the responsibility of the states, of government, to provide health and care to older persons. Closer home, we have the Constitution of Kenya, 2010, which enshrines the rights of older people, including right to health. And we have the National Policy for Older Persons and Aging of 2014, which provides a blueprint for cross-sector responses to issues of population aging and health as well. Then we have the Health Bill, which offers a broad framework for overall health responses, and the Kenya Health Policy of 2014-2030, which requires state organs and officers to address health needs of older persons. I'm glad to let this meeting know that we now have a national healthy aging, that should be healthy aging, and older persons health strategy in the pipeline. Actually, it is complete. It has been validated. It is under design, and we hope to launch it in less than a month to come. Just the process of developing the national healthy aging and older persons health strategy, it began back in 2013 when the healthy aging unit was set up at the Ministry of Health. In 2016, we had the first stakeholder meeting outlining older persons issues in Kenya. The second one happened in 2018. We justified the need for a healthy aging strategy. In 2019, the healthy aging unit was upgraded to a division within the non-communicable diseases department of the Ministry of Health. By 2020, we had the strategy being developed, and that was finalized sometime mid this year. So what is this healthy aging strategy all about? The vision is a country where all older persons lead an active and healthy life, and the mission being facilitating implementation of quality, comprehensive, and responsive person-centered health and social services support healthy aging. The strategy is guided by principles, and these are really universal, rights-based approaches, dignity, intergenerational solidarity, independence and autonomy of older persons, inclusivity of older persons, care and equity. The strategy has 4 strategic objectives, which I'll just go through quickly. The first one really speaks to what the speaker presented, promoting healthy aging across the lifestyles, the primary prevention. The second is strengthening health and long-term care systems for healthy aging and older persons' health. Again, this speaks to the early diagnosis. The third one, strengthening research, evidence and knowledge management on healthy aging and older persons' health. And the final is about strengthening advocacy, communication, and community engagement at global, regional, national, county, and community levels. I find this really quite a mouthful to go through all of them, but under every strategic objective, we have sub-objectives. I would rather I skip this and leave it for the convener to share. I hope there is quite some interference. Okay. Under the first strategic objective, we have a sub-objective on enhancing maternal childhood preventive, promotive, curative, rehabilitative, and palliative services towards healthy aging. We seek to enhance cognitive, physical, and social development for children under the age of 5, empowering communities to address ageism and foster healthy aging, promoting healthy behavior to minimize risk factors across the life course, strengthening promotive, preventive, curative, rehabilitative, and palliative services for men and women of reproductive age, empowering older persons on healthy aging issues, and improving the integration of the older person's health and social needs in relevant health policies and strategies. Under the second strategic objective, which is strengthening health and long-term care systems for healthy aging and older persons' health, we seek to strengthen governance, leadership, and the multi-sectoral coordination for healthy aging and older people's health. We seek to strengthen person-centered quality care for healthy aging and older persons' health. The third sub-objective is building capacity of health workforce and support caregivers on healthy aging and older persons' health needs. The fourth is strengthening the health products and technology supply chain for healthy aging and older people's health. The final under this strategic objective is to diversify health financing mechanisms for healthy aging and older persons' health. You heard what the previous speaker talked about, someone exhausting their entire savings and insurance while trying to manage a condition that was even inappropriately diagnosed or misdiagnosed. The third strategic objective is the strengthening research, evidence, and knowledge management on healthy aging and older persons' health. Has 4 sub-objectives, which include strengthening health information, knowledge management systems, and data governance for healthy aging and older persons' health, strengthening capacity for monitoring the UN Decade of Healthy Aging and related action areas at the national and subnational levels, strengthening capacity for research and generation of evidence through a participatory involvement of older persons on healthy aging and older persons' health, and finally, under this strategic objective, develop a research agenda through participatory involvement of older persons on healthy aging and older people's health. The final engagement global, regional, national, and subnational levels has 3 sub-objectives, which include strengthening communication and advocacy framework and tools on healthy aging and older persons' health, empowering communities with knowledge and information to promote healthy aging and older persons' health, and finally, strengthening social mobilization and advocacy for healthy aging and older persons' health. Other relevant strategies and frameworks include the Kenya Health Policy of 2012 to 2030, the Kenya National Strategy for the Prevention and Control of Non-Communicable Diseases of 2015 to 2020, and the National Cancer Control Strategy. I would like to leave it there and mention that WHO is currently piloting the Integrated Care for Older Persons guidelines, a document that is an instrument for operationalization of the decade of healthy aging. And it's really a community approach to primary health level and community level approach to population aging and healthy aging. I thank you for your audience. Over to you, Dr.
Wow. What a wonderful beginning. I say a beginning because this webinar is the first in a series of 4 webinars where we are all going to be enlightened about issues around cancer and aging. And if I can just ask a quick question, how old would you like to live to be? Maybe we can think about that. But the reason I ask that is because from what June has taken us through, we can see that there's progress. There's a strategy now coming up in Kenya for healthy aging. But beyond that, what are you and I going to do so that we have proper policies in place, a proper policy environment to support us when we are older? That's why I'm asking. Charles, kindly help Eric to set up, even as I am just giving these comments and reflections. And we welcome you, Eric. Unfortunately, you will have to go a bit faster than perhaps you had planned because time has given us kisogo. And I want to request all of us to be a bit patient so that we can end together. Kindly stay on a bit more, and we apologize for the delay. Welcome, Eric. Rick, we cannot hear you. Unmute yourself.
Hello, good afternoon, everybody.
Yes, now we can hear you. Good afternoon.
Thank you. So I'm Eric Ngereso. I'll be taking you through this session on healthy eating in terms of nutrition for the elderly. So I hope you'll give it the attention it deserves so that cumulatively each one of us is headed to that direction. We are aging, and therefore as early as we start to prepare to that age bracket, and therefore it will be prudent that we partake of what is required of us long term. So to start us off, I would say healthy eating is getting enough nutrients, that is now carbohydrates, proteins, fats, the vitamins and minerals to help reduce disease and achieve overall health and vitality. That's why, like when it comes to diet recommendations, the plot model as outlined on the slide reflects on how you can portion your meals and therefore equally there for the elderly, so that now it can assure optimal health long term. Now, to be able to ascertain an individual's level of nutritional status, of course, you can do what we call the body mass index. That is to mean you get to weigh the relationship between your weight vis-a-vis the height. Now, meaning, like say for males, if you want to get your ideal weight, you could take your height in meters squared and then multiply by a BMI of 21 to get your minimum weight. And if you want to get your maximum weight, you take your height in meters squared, multiply by 25. So assuming you are like say 1.7 meters, so you could do 1.7 meters times 21 to give you your minimum weight, and do also 1.7 meters squared times 25 to give you your maximum weight in kilograms. So for females, the same formula, weight, but now you do a BMI of 20 to get the minimum weight, and then a BMI of 24 to get the maximum weight. So, and actually through BMI, it actually helps to categorize individuals as to whether they'll be overweight, obese, underweight, or of normal weight, and therefore inform the nature of nutrition intervention to be given to the elderly at hand. Next. So WHO gives a classification of terming as underweight when your BMI is below 18.5. But now when it comes to normal range, 18.5 to 24.9, and then overweight, obesity has categorizations of class 1 obesity, 30 to 34.9. And then of course, for those who are morbidly obese or classified of class 3 obese, that's when we have a BMI of more than 40. So other than BMI, there is also another method of assessing abdominal fat, which is also still linked to obesity, which is the weight circumference ratio, or rather waist to hip ratio, where now like the waist circumference for a man should be preferably below 94 centimeters, and for women should be below 80 centimeters. Now, when you do the weight to hip ratio, ideally for men should be not more than 1. Should be as in if you've got a waist circumference of 94, then the hip circumference also should be 94. So now when you divide the two, they'll give you a ratio of 1. But for females, the hip ratio should be, the waist to hip ratio should be 0.085, meaning the figure for the waist, that is 80, should be much lesser than the hip. Of course, because of reproductive reasons, females will tend to have, a relatively wider hip than the waist. So that can be used in classifying body shapes. So you'll find that there are people who may have an apple shape as outlined, or a pear shape. So irrespective of the nature of body shape at hand, the risk of concern is they tend to predispose an individual to various conditions, especially now the non-communicable diseases, of which also cancer is part and parcel. And that's why nutrition interventions are holistic. Holistic to mean, other than now the core focus on cancer independently, you also now look into also other likely non-communicable diseases, like say diabetes, hypertension, dyslipidemia, or related, that also could come along. And therefore, once you do the assessment, it also now like cut through in using a single stone to address the other possible risks of concern. Because you realize that in the elderly, as they age, they also tend to have so many comorbidities at hand. Talk of like say arthritis also on board, and therefore holistically looking at the weight independently can also help in addressing much of the concerns at hand. Yes, so additionally, you could assess nutritional status by either doing the body composition. So you check for the body fat, body water, or lean mass, or even bone mass, visceral fat. And the table below it outlines the age group vis-a-vis for men and women, so that at a particular age group, you need to have a particular percentage of fat. That is now for the percentages outlined, and also for women as such. You realize that for females, they tend to have a relatively higher cutoffs for fat. Basically, of course, it's attached to reproductive reasons. And then for body water below the table, you realize that for men, 60 to 65% of total body weight should be water, and females, 55 to 60% of their body weight should be water. And basically, the parameters outlined form as the basis of follow-up in evaluating the efficacy of the nutrition intervention at hand, so that now you achieve the desired body mass index or health status. Next. So this is how we as Kenyans are eating today. You realize from the plate outlined, there'll be more githeri, but a handful of kales or even cabbage. And then on top of it more, so you realize that on that platter, nearly everything is fried. So of course, why the mention of frying? Once the food tastes relatively better, you're likely to eat more, and therefore predisposing us to the issue of overweight and obesity, which also has got a link to some forms of cancers, like say cancers of the colon or cancers of the stomach or related. And that's why the cooking method, the portions, and therefore the risk at hand. Of course, mentioning roughage, you realize that with inadequate intake of fiber, of course, there is a potential high risk of constipation-related concerns, which actually are a predominant problem among the elderly. That's why interventions to the effect of seeing an increased uptake of roughage in this population can actually help in alleviating polypharmacy in this group, because you realize that due to basically lack of intake of adequate roughage of fiber, this group of patients or clients, they'll tend to actually suffer from constipation, which also could come about because of maybe like the changes in taste over time, but also inadequate intake of food and also reduced intake of fiber can account for the constipation, which of course it means to any prescriber, it's easier for them now to be put on, like say laxatives to help in relieving their long haul. But of course, on the second plate, you can see there is a chunk of ugali. More likely it will be polished, that is grade 1, and then with a relatively larger portion of the meats. And you can see even if there is some kales and cabbage, but everything is fried. So equally meaning the better the tastier the food it is, the more likely an individual is likely to eat, and therefore predisposing the overweight and obesity at hand. Yeah, so for the uptown community, and I suppose also the same is also now trickling down to the villages as well, because of, I suppose, devolution. You can see there is a Fanta, some fries, and nyama choma, which also, of course, in the context of carcinogens, then it can predispose an individual to cancers of different forms. But of course, also now, the aging population in the cities, also as they decentralize, they also tend now to the millennials also the price on the right side. Of course, it has become relatively easier nowadays to access junk via platforms like say Jumia or related. But you see, the concern long term is the predisposive risk to cancer and related concerns long term. Next. Now, what are the potential barriers to healthy eating? Of course, the aging population, whether working or not, or for those who have not been working, they'll actually mention irregular work hours. So they don't have time to prepare the right meal. It is also the aspect of lack of willpower, but you see now willpower has to come from within the as pertains to the potential life risk of an unchanging usual behavior. Busy lifestyle, but you see the unfortunate is, yes, you could be busy, and then now you use your lifetime savings to now address medical bills, as you've heard earlier from previous presenters. Giving up foods that I like. So of course, bias in terms of their customization. Somebody has been to over time, like say in a city life, if he or she was even to be like say in a home, or maybe he or she has retired to the villages, it's easy for them to recall what was normal to them in their prime years. Then not knowing enough about healthy eating, of course, that now brings the question of whether we as dietitians, nutritionists are reaching out enough to the populace so that now they get to know what is right. Cooking skills, of course, you realize earlier mentioned, more often frying is the cornerstone, and you see the risk to it is better taste and therefore increased portions a person is likely to clear. Lengthy preparation, that comes in the context of cost cutting. People would want something that actually is prepared much faster so that they pursue or proceed on to their busy schedules. Next. So there is also the aspect of limited choice when I eat out, but you see in this case, there is the option of you having to carry what is best suiting to you. Not enough food to satisfy hunger. So as in this case, heri chakula ama bora chakula sio chakula bora. And then experts keep changing their minds. Of course, now anybody in the street could come out to give opinion as pertains to what is healthy or not. And that's why specialist consultation or referral is ideal. So now you demystify some of the myths surrounding food choices. Healthy food is more perishable. So of course, majority of the community will be like, say, especially now the population you're talking about, the elderly, they would rarely have, like, say, the items of interest, like, say, the refrigerator to store their food for long term. Therefore, they'd rather go for what is readily available in their locality. But you see, in the long term, there is the risk to it. And then storage facilities, of course, as I mentioned earlier, lack of access, especially in this population of concern, because also they've got shrinking incomes as time goes by. And then limited cooking facilities, of course, also besides the facilities, also as they age, then the productive capacity also comes down. Healthy food is more awkward to carry home from shops. So of course you can imagine now if you're in Naivas and then now you walk away with the cassava protruding in your carry bag, then somebody has got hamburgers in a carry bag, besides you. So you appear to be awkward, and therefore that tends to shrink somebody's willpower to do what is right for them. So feeling conspicuous amongst others, this is to mean, for instance, if you're at the workplace, and then now your lunch is githeri with some cabbage, possibly maybe boiled and related, then everybody around you is doing some fries, some soda, and even some nyama choma. Of course, it tends to now demean you internally. So next time you're likely not to carry what you are used to, and instead now join the crowd, because actually as the adage goes, if you can't beat them, you join them. So the willpower, as earlier mentioned. Then cost of food versus purchasing power. Of course, lately with the COVID being a context of concern, then incomes have shrunk in households, and therefore whatever comes their way is what they're likely to put on the table. Next. But what are the concerns long term? Lifestyle diseases are key and of interest, like say talk of diabetes, hypertension, cancer, which is now the concern at hand, liver disease, COPD, cholesterol issues, Alzheimer's disease, heart disease, and the rest of such. There is also the aspect of psychological, emotional disorders, like low self-esteem. You can imagine now an aged adult who now, because of osteoarthritis, he or she is not able to walk anymore. And therefore, in this case, of course, the self-esteem, feeling also stigmatized can be issues that could affect their psychological and emotional well-being. Depression, for those who have tried to lose weight now, they're not actually succeeding given the limitations at hand. Decreased performance, of course, in this case, it means running household chores becomes a problem. And of course, long-term, it will be death because of the possible comorbidities that may accompany this group of clients. So how can you modify our eating habits? In this case, nutritionally, we recommend that half of the plate should be veggies. And as I had earlier mentioned, constipation being, and even micronutrient deficiencies being a concern in this group of clients, the veggies, and also including the fruits and vegetables, the vegetables and fruits, basically they have the macronutrients of interest in alleviating micronutrient deficiencies, but at the same time also helps to address the concern of constipation as earlier alluded. And then, of course, starch for energy, proteins for tear and wear. So half of the protein veggies are quarter starch, a quarter protein. That should be an ideal model. But now, of concern is you could be talking about that plate model, yet when you look at the picture on your right, that's the same fellow now is also recalling on how life has been before making now the possible decision of change as we look into it. Go ahead. So healthy eating or smart eating would mean you serve small meals as outlined that literally would say after every 3 hours during the day, have something coming your way so that now you maintain steady energy intake. So equally for the elderly, small meals could come in to counter because you see now with the time, the level of activity in this group of clients tend to go under, and therefore they need steady energy supply long term, which now can be offered as a spread out in terms of every 3 hours. And actually to make it effective, it would even mean now if you are to do alarming to keep them on toes. But basically is because at times you may find he or she who is hungry may feel lethargic, but you see, it could be assumed she's sick, and therefore for the family to simply think of rushing to a facility for maybe for some workup to find out what could be cutting, but energy gaps. Now, of course, you can see some fries are there, but remember what you're mentioning is once in a while is no harm, but it shouldn't be the habit. Next. So the food pyramid outlines on how our intake should be, although it's not I mean, you look at the bottom of the pyramid, basically you're looking at the bread, cereals, rice, and pasta, but of course you want whole grain options. Basically, they're coming in to provide us with energy. But whole grain, of course, because of the fiber being of interest, so that now they have slow glucose release into their circulation, so they feel energized long term. And then the fruits and veggies coming for the purpose of micronutrient deficiencies, the meats coming for tear and wear, and then little fats and oils or maybe sweets if necessary, so that now actually to aid in topping up on their calorie intake for those who it is really necessary. So in summary, I would say limit foods in which the main ingredient is sugar. So sugar usually is a recipe for microbes, but at the same time, sugar, if not expended once consumed, of course, now it is stored in form of fat, and therefore now accounting for the overweight and obesity that could be a threat to this group of patients, which actually it means if overweight or obese, even the cost of care for this group of clients becomes high, because either if you are to even take them to the hospital, it means you also require an Uber. They may not use mainstream transportation mechanisms, but also look at the aspect of saturated fats. Of course, with the shrinking incomes, they're likely to use solid oils or the solid fats instead of the preferred polyunsaturated fat, oils. So fried foods, cakes, pastries, fatty meats, butter, cream, although they are cheap to access, but now they could be countering the interest at hand in the discussion of preventing cancer. So use of healthy oils from foods like avocado, groundnuts, corn oil, or sunflower is preferred in the cooking. But the key word is sugar. Remember that this, of course, as people age, their taste buds tend to also shrink in terms of perceiving taste. So it's a very delicate group to deal with when it comes to saying no sugar, but actually it's an entry point in helping alleviate the burden of concern. So the food could either be grilled, boiled, steamed, you could bake, dry roast instead of deep frying. Of course, as I said earlier, once deep fried, it tastes better, and therefore there is the bias of likely eating more. Limiting salt. So salt is still attached to the sugar story. And that's why you see add salt. Somebody may have the need to add at the table, but you see, the of interest is ideally, if possible, they would rather eliminate. And that's why recommended options could be they could use maybe ginger, hoho, dhania, garlic to improve on the flavor and taste of food. Maybe also lemoning or even pineapple, so that at least long term, the food has some level of taste other than the aspect of salting. Next. So portion control, so you're saying limiting serving sizes to maintain healthy weight. Of course, what affects portion is attached also if somebody say has poor eating habits, say maybe they have once a day or twice a day, usually they'll tend actually now to overeat in the second session for the miss out that they That's why, as outlined earlier in the healthy eating or the healthy snacking, smaller frequent options are preferred. Now, single or 2 meals a day, as an eating pattern. And then 6 to 8 glasses of water daily. Of course, it helps in addressing the constipation concern, but also it is also a limitation for those group of patients in that group, or the clients in that age bracket who could be having maybe renal or heart conditions. So the 6 to 8 glasses may be limited to that population. So that because you see, it may counter the medical outcomes because they require food restriction. Those such conditions require food restriction. But also you will find literally the elderly usually have an averted taste for water. And that's why, how can you improve on the intake? They either could be in form of fresh juices, because they'll tend to improve on their taste interest, or you could lemon the water. And also it's preferred if you give it as warm rather than literally being cold. But of course, sipping across the day is preferred. Of course, besides the role in constipation and related concerns, of course, water will also help in eliminating the toxins that may tend to build up in the system over time that also now could be pro-carcinogenic. And then maintaining physical activity by keeping up the activities you enjoy. So basically it means the elderly may, although they could be frail, but now they need to be engaged to make a walk. Walking is the gold standard, so that at least now they can disconnect from their life's stressors, or the discomfort of being sedentary. So in conclusion, I would say throughout your life, you should adjust your overall intake of food according to how physically active you are. So of course, in this age bracket, as they age, they tend to be less active. Therefore, now the portions of food they consume should also be adjusted based on the activity level. Otherwise, now the risk of obesity can be a challenge in that population. So it's also important to ensure that your diet remains balanced right throughout life. So of course, you need the proteins, the vegetables, the starch, and also, of course, the roughage as outlined, and even water. And then sure, you eat a wide variety of food so that now you can be able to get the varying nutrients from the respective diversities that nature provides. Next. So here we are
Thank you,
saying,
Eric. Kindly, let's bring it to a conclusion.
Yeah, sure. So I think I'm done.
Okay.
Great.
Yes, we can see that no feast, no fast. Balance is the key to good nutrition. So within each of us lies the power of our to health and sickness, to riches and poverty, to freedom and to slavery. And it is we who control this and not another. Wow. I want to thank you very much, Eric, for the wonderful presentation. I hope we were able to follow. I think we were, and I must say that it's very insightful, because it's also something that applies to ourselves, even as we think about our clients, our patients. It's something that we must apply to ourselves. So I'll allow just 5 minutes for any questions. Carol or Charles, if there are any questions in the chat, kindly read them out, or any comments that I may have missed, kindly read them out at this point. And if there's anyone with a question, kindly raise your hand so that we can see that you would like to ask a question or comment. Charles, you can help me to see if there are any hands. I don't see any. So, any comment from anybody? So this means that we either got everything or we missed everything. I want to believe it's
Um,
the first. Okay, there's yes, Jude. You have something to add?
Just a comment, first to appreciate the presentations by my two colleagues that have spoken, and to reinforce the message that for us to experience healthy aging, we have to live healthy throughout our lives, adopt a life course approach, right from when we are children through to the point when we qualify to be older persons. The primary prevention that the facilitator spoke about, the healthy eating habits, the exercises, those are things that we don't have to wait until we are 60 to do them. What we do today, what we did yesterday determines what we will be tomorrow. Thank you. Over to you, Dr.
Thank you, Jude. I see one comment in the chat. Gloria says, thanks for the good presentation. And I think I cannot end it any better than you did. Jude, let's adopt a life course approach. Let's be advocates now that we have the knowledge. And please join us for the next webinar. I would like to invite Charles or Christine from Kenco to perhaps any final remarks and close.
So thank you very much, Dr. JP, and thank you to our facilitators for today. I think we've really learned a lot. So I would like to thank the participants for availing themselves. So please join us next week on Thursday. That will be on 4th November. We are going to have a session on cancer treatment, and we're going to be looking at cancer treatment among the aged populations. Going to be looking on medical oncology and also radiation oncology, and how we can come up with the pediatric assessments for the aged. So please plan to join us. We're going to be sharing the Zoom link for that webinar. Also, we are going to be reimbursing Kenya shillings 500 for the data bundles. So please do text us your number to our office number. That is 0799 400 875, so that we're able to reimburse your data bundles. Otherwise, thank you very much for joining us today. Thank you.
Thank you, Charles. Perhaps you can write that number in the chat, Charles, so that before the participants leave, they can have the number. And also maybe support it to the registration that we did before we joined the webinar. So I want to thank all of you for joining this evening. I want to thank especially the presenters who have spoken very well. We have learned a lot about policies on healthy aging. I'm sure this is something that most of us had no idea about. A lot we have also learned about primary and secondary prevention of cancer, including healthy diets. So I wish you well as you live, and see you next week. Thank you very much, and God bless you. Bye.
Thank you and bye-bye.
Bye.